Good morning and welcome to Global Healthcast, brought to you by Global Health Press. Once a week, we bring to you news and views about vaccines and vaccination and infectious diseases. I am Joe Schmitt, and with me, as always, is Dr. Melvin Sanicas. Good morning to Switzerland. Good morning, Melvin.
Good morning, Professor Schmidt, and good morning, good afternoon, good evening to those who are watching us today.
Thanks for joining us, and these are the topics we're going to cover. RSV hospitalizations have worse clinical outcomes for older Americans than influenza and COVID. A study from South Korea shows higher risk of new-onset post-COVID autoimmune autoinflammatory disorders. Cases of dengue fever in Switzerland and Italy. And finally, a little bit more information on acute respiratory infections. Viruses are needed. A new study from Israel is very interesting and gives new insights into the pathogenesis of bacterial pneumonia. And here we start again with Melvin and respiratory syncytial virus. Melvin, what's the news?
Yes, so although hospitalizations for respiratory syncytial virus or the RSV are less common than those for, let's say, flu or COVID, they are more severe and more likely to occur in adults aged 75 and older, according to this new data published in Morbidity and Mortality Weekly Report of the US CDC. The study looked at adult hospitalization for RSV in the United States from February 2022 to May 2023. And over 5,000, almost 6,000 adults aged 60 years older, 60 years or older, hospitalized with acute respiratory illness and laboratory confirmed RSV, SARS, and influenza infection were prospectively enrolled in the study. And this was conducted in 25 hospitals in the US. Severity of illness was based on several outcomes: standard flow oxygen therapy, high flow nasal cannula or non-invasive ventilation use, intensive care unit admission, invasive mechanical ventilation, or death. And overall, 5.3% of adults were hospitalized with RSV, 81.8% with COVID-19, and 12.9% with influenza. But this actually does not show the whole picture, because even though there are more COVID and there are more flu cases in the cohort, those infected with RSV had serious cases, more serious cases.
Very interesting. Actually, I'm wondering, Melvin, if the low frequency of RSV detections is a function of the fact that people don't test for RSV. So if you would test everybody for RSV, everybody who has a runny nose, you probably would find more RSV. We have been using a multi-test, which detects RSV, COVID, influenza, A, B, and also the adenovirus. And we found that RSV is more common than influenza. And interestingly here, this is not the case. So maybe it's a question of not testing for RSV. And then the picture would be RSV is more frequent and more severe than influenza.
That could be the case. Of course, testing is always something that would skew the data either way, right?
I guess what we see is the tip of the iceberg, people who make it to the hospital then, right? This is the story. People go to the hospital and then they're tested, right? But not outside. But yeah. Very interesting study, and it is very timely because 2 vaccines are now licensed for subjects 60 plus to receive, or are even recommended in the US for use if you want to prevent RSV infections. There are 2 products now.
Yeah.
Very good. COVID, you have, Melvin, you have another item on COVID and consequences of COVID, and I think this is really, really interesting.
Yes, and so this, the next slide will show you a study from South Korea, and the question is COVID-19 associated with an increased risk of autoimmune and autoinflammatory disorders? So this was published in JAMA Network Open, and researchers identify a significantly high risk of multiple new onset autoimmune and autoinflammatory connective tissue disorders after COVID-19 infection, some associated with illness severity, but vaccination lowered the risk for this. Although this is a retrospective study, it gives us some insight, right, of how COVID actually increases your risk of getting autoimmune and autoinflammatory problems. And it also gives us an idea that vaccination lowers the risk. And I think this is very important because it really shows us that the benefit of vaccine is not just infection or serious diseases, but other potential causes of COVID infection. And in this study, they actually show that the risks of alopecia totalis, psoriasis, vitiligo, vasculitis, Crohn's disease, ulcerative colitis, rheumatoid arthritis, adult onset still disease, Sjogren's disease, ankylosing spondylitis, and sarcoidosis were associated with increasing COVID-19 severity.
Very interesting. So COVID, the SARS-CoV-2 really triggers the immune system in various ways and has funny consequences. And the whole picture only now evolves. Yes. I'm just thinking while you were presenting this, the one other disease that I remember that has other diseases as a consequence is group A streptococcus infection with glomerulonephritis and with rheumatic fever, which are distinct entities. But here, what you see is autoinflammation resulting in different diseases that are not all own entities, but they are triggered by the pathogen. It's very interesting. Very good. You have another piece of information from dengue. We had a whole series on dengue, and now dengue is spreading. And this is your next piece, Melvin.
Yes. So here you will see these are articles from Swiss Info, and the other one is about dengue update in Italy. So two countries where we expect dengue to not be an issue, right? I mean, it's not yet a global public health problem, but it might be in the future. So these are news articles from Switzerland and Italy. And on the left, you will see that the Federal Office of Public Health of Switzerland said that there were over 150 cases of dengue reported since the start of the year, compared with only 68 in the previous year, in 2022. And in addition to dengue fever, the number of cases of chikungunya has also risen sharply, and the number of malaria cases is following the same trend. And according to the Public Health Office, the increase in case of dengue and other mosquito-borne diseases is due to the resumption of travel after COVID, the pandemic, and the figures are back to pre-2020 levels in terms of traveling. And the cases reported in Switzerland exclusively concern people infected abroad. So these are not local cases, but cases from people who travel in dengue endemic countries. And on the right, for Italy, you will see that there are locally acquired dengue cases in multiple regions in Italy, with the most in the province of Lodi, and then the province of Rome also has some, the province of Latina also has a few. And the authorities in Italy have implemented vector control measures in these affected regions, and they have urged the public to really take mosquito bite prevention measures, because this is really how you prevent yourself from getting mosquito-borne diseases, right? You prevent the mosquitoes from biting you. But this is just showing us that in countries that traditionally you don't expect mosquito-borne diseases, we might be seeing more and more every year because of climate change, because the warmer climates can now accommodate these mosquitoes. And also we've seen in other studies showing that because of the warmer climate, the mosquitoes are breeding much faster now. So this is something that we have to accept, that because of the changes in our climate, we will be seeing more of these in the future.
The question I would have, if in Italy or Switzerland, there is a reservoir for the virus other than humans, and if all humans who suffer from dengue are immune, then there is no viremia, so there cannot be any additional transmission. Or does the virus persist throughout generations in the mosquito?
Well, what we know is there are now areas in Europe with Aedes albopictus, right? The species that can live here, can thrive here. And even though the reservoir is, as you say, humans traveling to endemic countries, right? We actually don't know because 70 to 80% or even 90 in some studies are asymptomatic and don't really show anything, right? So they could have the virus, but they could not show any symptoms and they could be bitten by these mosquitoes and that could transfer. So all of these are, of course, theoretical, right? But it means that the risk will not be zero then because of all these different factors.
Interesting, yeah. Melvin, I have a little bit on respiratory tract infection, and the reason for that is that we certainly have a start of the respiratory season in the northern hemisphere. And while summer is approaching the southern hemisphere, I guess there the respiratory tract infection season ends. What I want to show you here is from a small island close to the or above the polar circle that was hidden by ice throughout the year, except for summer, that the common cold is a common warm. And that is the reason why the term common cold should not be used, because it's wrong. What you see here in the brown line, this is temperatures. And as the temperature goes up, the ice is melting, and ships come for the first time, only 3 months possible, they can reach the island to, you know, take the charcoal that was there to other areas in Europe. So when the ships first arrived, this is when the respiratory season started. So the important thing in respiratory infections is not the temperature, but the wind or the humidity. The important item is really that you are exposed to a pathogen. And once everybody is immune, the pathogen will disappear. I mean, that is the aim of quarantine, reducing exposures. It gets a little bit more interesting. So the important message is common cold is wrong, right? That's what you should avoid. Yes, there is a connection between climate factors and infections and exposures, I guess. So influenza, RSV, and adenovirus increase with lower temperatures. Rhinovirus is increasing with humidity. It's an enterovirus. RSV, we had a model a couple of years ago where you can predict outbreaks with a precision of 2 weeks. There is a rhythmicity in RSV exposures and transmission and infections. So this is very interesting as well. And again, winter, summer, you have your outbreaks in the northern, southern hemispheres. Near the equator, you have respiratory infections year-round. So again, the term common cold really is a misnomer, and you better don't use it. Now, what should you use? I guess ideally, if you are a medical doctor, you need, for a diagnosis, you need a pathogen, you need an organ, and you need a modifier or an exposition. And this is very important. If you are pregnant, influenza is different. You have a higher likelihood of dying from influenza. This is a modifier, right? But you're also exposed, but you're only exposed on the northern hemisphere in winter. So this is sort of conditions that change the disease, but the disease for the individual is the organ and the pathogen. Now, the interesting thing is if you know 2 of the 3 elements, you can predict the third. We know very much, for example, if you have cystic fibrosis, that is the modifier. You will have pneumonia again and again, and the most common pathogen is Pseudomonas aeruginosa and not all the other organisms that may cause pneumonia. And if you do have, if you have pneumonia with a Pseudomonas aeruginosa, and this is pneumonia, you could predict you are on a respirator, you do have leukemia with a low neutrophil count, you have cystic fibrosis, or you're a burn patient, for example. So you can really, this all has to fit together, and this is how this is all getting important, that you come up with a proper diagnosis and don't use the term common cold. Now, today I want to look a little bit into the pathogens. And the pathogens are important because there is new insights. Number one, they are colonizers. 50% of young children and 5% of older adults have streptococcus pneumonia in their throat, and it doesn't matter, it doesn't usually cause disease. And if it would cause disease, you can treat it with a beta-lactam antibiotic. Then we have the so-called non-colonizers, and there are like 5 bacterial species, and they are sensitive to macrolides: chlamydia, legionella, mycoplasma, bordetella, pertussis, and parapertussis. So these you can treat. If you are infected with them, you're usually sick. They are non-colonizers. Now, with regard to viruses, we have like 14 and more epidemic viruses. They come every winter, as I showed you, or year-round near the equator, and they are listed here: the coronavirus, COVID virus, RSV, adeno, influenza A, B, parainfluenza, human metapneumovirus, enterovirus, rhinovirus. There are epidemic coronavirus, reovirus, and adenovirus. These are the big groups, the big challenges. Now, the important new information is this is associated with an infection of this. And I dare saying it looks as if you only get a bacterial pneumonia with streptococcus if you are infected with one of these viruses. And for this, I show you recent data from Israel, from South Israel to be precise. There, our colleague and friend Ron Dagan is following respiratory infections for years. And what he observed is that pneumococcal pneumonia and pneumococcal infections disappeared during COVID. Children were still colonized with streptococcus pneumonia, but there was no bacterial pneumonia during COVID. Isn't that interesting? So this already tells you, if you don't have this, this will disappear. And it also has implications that if you are vaccinated against this, you will protect against this, which I think this is absolutely fabulous new insights. It is breaking news for medicine. This is really great. Now, in addition, here is what he did. After everybody in Israel stopped wearing masks, stopped using hygiene or washing the hands all the time, stopped visiting friends and being in close contact out there in parties, whatever. When this stopped, he followed how these respiratory viruses reoccurred in the population. And with these viruses, Streptococcus pneumonia infections occurred at the same time. And the nice thing is these viruses were reintroduced one by one. They didn't all come at the same time, but one by one. And from that, Ron Dagan was able to predict the percentage of these viruses for their contribution to Streptococcus pneumonia or to bacterial infections. And this you see here. What you see here is that RSV contributes, I would say, 70% to bacterial pneumonias. Human metapneumovirus, that may be 15%. I'm guessing, right? And a little bit is parainfluenza and a little bit is influenza. So I think this is very, very important new insights. The respiratory viruses, some of these respiratory viruses, they are relevant, and you need an infection with these viruses. Otherwise, you won't get infected with the bacteria, specifically with the pneumococcus, as I showed you. Melvin, I think this is breaking news. What do you think?
Yeah, I think it has a lot of implications for vaccination and public health. So this is really something that we should be looking more into. Yeah.
Yeah, this is for children. The work has to be done for adults as well. So I think this is really very, very interesting and has a lot of implications. And maybe we follow up on that in a later Global Healthcast. This was our Global Healthcast for today. And Melvin showed you that RSV hospitalization have worse clinical outcomes for older Americans than influenza and COVID. Very important, because now you can vaccinate against RSV if you're an older adult. The Korean study that showed that COVID may trigger autoimmune, autoinflammatory diseases. Then we discussed that dengue is rising in Switzerland and Italy, or was rising. And I showed you that respiratory viral infections are a prerequisite for bacterial pneumonia. And I think, Melvin, you have in the end a very nice cartoon that you can bring to us and explain it.
Yes, I don't think this needs explanation at all. People will be able to relate to this, but with all the talk about artificial intelligence, chat GPT, and all these things, large language models, I think it's really important to understand and realize that all these artificial intelligence is really no match for natural stupidity.
That was our Global Healthcast 51. Thanks for joining us today. My name is Joe Schmitt, and with me was
Melvin Sanicas. Thank you, everyone. Stay safe. Get your vaccines soon.